don't you just love it when things go to plan? When you're in a state of flow, when the magic happens and jobs get done. And the people who are good at this kind of stuff, they plan ahead. They work out what they need to do a day in advance. They make sure they have all the things they need to do it. And apparently they just power through things and tick things off. But in healthcare, you know one place that's really hard to do? The emergency department. I'm going to hazard a guess that for clinicians that work in the emergency department, no 2 days are the same. Who knows what kind of issues patients are going to present with. But even in those fast-paced clinical environments, it doesn't remove the fact that clinical documentation needs to get done. Patient notes need to be typed up. Referrals and prescriptions need to be written. So to have any chance of doing things in the ED well, you're going to want to have an efficient way to take notes and write things down. Like for example, with voice-to-text technology.
So today I'm at Microsoft's office in Sydney at a breakfast event featuring networking and food, but also some great learnings and presentations shared by Dr. Pieter Nel and Dr. Andrew Brier from Mackay Hospital, who've implemented voice-to-text technology in their emergency department thanks to Nuance and Dragon Medical One. I got to sit down with Peter and Andrew after the event today to record this podcast episode for you. You'll hear about how speech recognition technology is giving time back to clinicians, how the Mackay HHS has improved communication between healthcare professionals using voice-to-text tools, and plenty more too. Collaboration starts with a conversation, Team Health Tech. Well, let's make it happen. This is Talking Health Tech with me, Peter Birch, featuring content and community about technology in healthcare.
Great to have you here for the podcast. I heard you both in the room earlier here at Microsoft talking about Dragon Medical One. But firstly, set the context for those checking out this podcast episode. Who am I talking to? Andrew, I might start with.
Hi, I'm Dr. Andrew Brier, I guess. I'm a specialist emergency physician. I'm based in Mackay. I've been back there for 5 years as a consultant, but I've actually done 75% of my entire medical career up in Mackay. I've had to flit around to some other bigger hospitals, but yeah, I've ended up back in Mackay. That's where my wife's from, where we've got our family set up. So no plans to move anytime soon. And I love the work there. It's a proper mixed general ED. So we never go on bypass. We take all acuities, all ages, all genders. And because of our large catchment area and being a long way from tertiary level help, we manage high levels of trauma and that as well. So it's a very interesting and very rewarding job I do.
I love the fact that we can get the time from a busy clinician, particularly in an ED environment where we're probably arguably the most busy clinicians in the hospital, or at least sense of urgency is really important. So I appreciate that you've been able to make the time and come down to Sydney and have a chat today. But Peter, tell us about yourself.
I'm Dr. Pieter Nel. I'm also from Mackay, spending the last 13 years in Mackay. Originally trained and worked in South Africa and see the light to come over to Australia and join the journey down under. I was originally the clinical director of emergency department. The journey we had was to put Mackay on the map through a few different areas, and we did first focus on get our emergency department accredited with ASIM for training. Interesting, I remember Andrew as an intern through the hospital. Then we did move to a brand new facility, which is state of the art. Originally been planned to go digital, but we missed. That was a bit slow in Queensland. I was involved with the rollout with Cerner product in Queensland, EMR, in Mackay, the medical lead, and then also involved with a statewide rollout. My background is a rural generalist, so my specialty is emergency medicine, obstetrics, gynecology, and I play in the area of medical administration, also a bit more daunting for me, but I'm happy to play in that area. I'm still working clinical, 0.5 clinical on the floor, and I feel it's important part to understand the digital journey and what is the challenges out there for our clinicians. but also lessons learned, which you then can bring back and implement in the digital journey.
Yeah, there's no better way to feel the problems firsthand, right? When you're still keeping a hand in the clinical. So, and I hear many clinicians want to make sure they're doing both.
Absolutely. You learn to cry with your family and to laugh with your family, and that's how you build up respect and trust. And then that's absolutely one of the lessons I learned going through the digital journey. Lessons I learned very hard in a sense that a bit of duck and diving when we did get the EMR in. So very well remember that lessons.
Yeah. And good support from interns, no doubt, as well. So there you go.
We're on a very different system back then, as in paper and through a lot of it.
And on that point then, because we're talking about different technologies, you spoke about digital journey through Mackay, and today we're talking about speech recognition or voice to text and some technologies in that space. Peter, tell us a bit more about the journey of implementing some of this technology in Mackay.
As I say, I did take the lessons away from what I learned through this EMR implementation. Mackay is unique, it's regional, but it's got also about 5 to 6 generations of clinicians there. So how do you plan for a generation which is close to retirement versus the new generation coming in? And I did definitely learn a lesson there and bring it back, speech recognition. What can it benefit all of the clinicians? And I did focus specifically on the seniors because they're the ones who's the influencers. They're the ones who are the role models for our new generation coming through. And that's the ones who really adapt. If they see a senior clinician can use it, why can't I use it? Yeah. At the same time, I did focus on create a bit of a competitive model there. And myself is very competitive. I was always with EMR, not one of the fastest typers, so I had to adapt how you use the system. So they can compete with this fast typing young generation who's looking around while they're typing and I'm sitting there focused on the screen. And that's when I realized DMO bring a complete new concept to the table. It will benefit everyone. The fast typers is only a small percentage of the fast typers, but even them could benefit of it. So that was my first focus, how can it reduce time in the document and the record. And as we roll out, we realized this is not the only benefit we had because there is so much benefits coming out of it.
It's interesting that you clicked into the point around typing speed, and there's so many things for a clinician to learn to be a good not just to become a clinician in the first place, but to maintain at least a semblance of relevance on a day-to-day. Always new information, but if it means then they're spending a lot of time trying to work out the tools or just being held back by things like typing, that feels like a bit of an unfair advantage. So having some technology to be able to empower clinicians and kind of get over that hurdle must be pretty important.
It's very important. The light bulb moment for me was when I was doing the typing test. So we did require every clinician who come for training need to do a typing test. Typing their away at 26 to 30 words per minute.
Were you two index fingers as well?
Two index fingers looking at the screen.
You can get pretty fast like that. Yeah.
And the fingers start, fumbling around and start sweating. And after a minute, I look at the notes and I thought, wow, there's mistakes. Yeah. What does my note really tell me? I can't read the story. Then we'd start doing DMO training, and specifically it comes out beautiful. No spelling mistakes, no grammar mistakes. Tells the story, the narrative is so good. And I compare it to and say, I don't want to put my name on that other notes I had versus the one now. I could immediately see the reduction of time for clinicians.
Yeah. And, we've spoken a bit about the benefits for a clinician, and there's many more that one could think about there too. But I think you touched on as well that there's benefits not just for clinicians in having some of this technology, but also for patients as well?
Absolutely. For clinicians, the other benefit was releasing time. So you can spend then at the bedside with your intern, do assessments with the intern. So release and support that intern or the other PHOs. The other benefit I've seen was for your nursing staff. They just feel supportive all the time. If you can look up and see they've upset, you walk to them and said, "Can I help you with something?" They feel so much supportive there. For the patients was absolutely the effect. You've got clear notes there in the patient journey. It's the patient safety and specifically around handover between clinicians. The story is in front in real time. If you do your notes 5 minutes before handover, and the next clinician can see that note, so that it's absolutely helpful for the patient on this journey. They can quicker get to the end of disposition or going home, and the next patient can be picked up.
Andrew, I want to go to you for a second because, you're in that busy ED environment day to day, and we're talking about using speech recognition technology, which for some people might be quite different to the way they do things now. And when I think about doing something different to how I do it now, it sounds a lot slower, like that learning curve to kind of pick it up. How did you find, firstly, that kind of shift from doing stuff the old way to doing what you're doing now?
Yeah, so I can see exactly why you think it might be slow, because I originally thought that as well. I was highly skeptical that this technology actually had a place in a very busy and very noisy emergency department.
Because it's fine if you're sitting at your desk and you can talk to your computer and be like, hey, I know it's handy, it wrote down the thing, but you're moving around, you're doing it.
I was reluctant, and when I first got invited to be part of a pilot project, I didn't really engage with it that well. My microphone sat in my locker for the first week or so, and then really I just I've said I'm going to do it, so I have to give it a go. And within even that first shift that I did it, I was quite intrigued. I certainly was not any slower, just using the voice to text functionality, and hadn't even unlocked some of the things I'm doing. Within a few shifts, I was addicted to it, and now I'm just fully dependent on it.
That's interesting. You've gone from just this is a handy tool to have to being totally dependent on it. Why do you say you're dependent on it?
Well, I just know that where I'm sitting now, I'm a far more efficient clinician than I was 2 years ago. Before I was using that. So if I was to have that taken away from me, I would just realise I am not doing the job that I'm capable of doing in terms of efficiency and my, I guess, my pride in my work, and that would suffer. Yeah.
Something that you mentioned that I thought was really interesting, and something I'd even love to be able to do, not as a clinician, is make use of, I think you called it unusable time. Unpack that a little bit for me and talk to me about what you meant.
Yeah, so in the talk I'd said there's two elements to unusable time. So the first one is we have extraordinarily time compressed moments. So very short periods of time, say maybe 30 seconds, 60 seconds or so, between tasks, where normally you would just go from one task to the next and not make use of those fleeting moments. So probably the best example would be during a busy shift when you're trying to turn over a lot of quick patients in the wait room because you have no beds inside. And then you get pre-notification for a severe trauma or resuscitation that's going to land in a few minutes. I can quickly eyeball one patient, and then in the past I would basically say, yes, I think they need an x-ray, or I think they need some blood, can you get someone to do it? Whereas now, because I'm more efficient in terms of ordering, I've got some order sets that I can order quickly. So the x-ray will be done, I will order it, and it can happen before the next the junior doctor picks them up. I'll even have time to auto-generate a note, so one click on my microphone will open a note. I can insert a quick S-bar, navigate through that and quickly put down a plan in 20 seconds or so, sign it off and everything. So we're making use of that time so that the patient is not sitting idly in the wait room. They get the x-ray, the bloods are done, but there's also communication to the junior doctor as what I'm thinking as a senior clinician the likely progression for this patient is. And I still get to the resuscitation on time. The other unusable moment is when you're on the move from one part of the department to the other. Typically nothing happens in terms of doing work in that time. So I use my microphone. It's plugged into my mobile workstation, and as I'm moving, say, from triage to resuscitation or from the acute area down to the handover room, I can keep dictating notes. So it could be that quick S-bar I've done for the wait room patient happens while I'm moving to resus. Or I've literally done 2 discharge letters, so GP letters, while I'm walking from the acute area down to the back room where handover occurs at night. So it's less documentation I have to do at the end of the shift because I'm making use of those small moments in time.
Like I think about, might be showing, I was going to show my age, that makes me sound heaps old, but like a little bit. So maybe 10, I'm sure it was about 10 years ago, I kind of gave a bunch of speech recognition tools a go. And, even these days when you play with Siri, Alexa, and whatever the voice tool is on your just standard kind of retail phone, it doesn't handle too well with, especially when I sound overly Westy and Australian. It doesn't do too well. But I'd imagine it wouldn't do too well with clinical stuff as well. But Peter, like in terms of your experience with accuracy and stuff.
Brilliant. I was very skeptical about how will it cope with my accent. Siri couldn't cope with my accent. Alexa, neither. Previously versions of Dragon couldn't cope. So I was very skeptical, and within 2-3 minutes I see, well, number one is it understands my accent very clearly. You can train your Dragon, so it can specifically in medical terminology train it to spell correctly certain words like rivaroxaban. Cabbage is not the cabbage we eat, but the CABG, which we use for in the heart conditions. So it was really astonishing to see how it trained as well as it remembers. So next time when you use it, it's come out beautiful. Yeah. I tested in a noisy environment with next to kids screaming and yelling. It no problem with it. It still recognizes it. During COVID, completely recognize it under your mask with your facial screen. You can use it with your Apple AirPods as long as it is on noise cancelling, no problem. So advantage of dictating anywhere, any time, in real time. It's a huge advantage.
Hypothetically, this technology now enables you to document so much more. Does that then create so much more noise in a record that then if someone went to go back and look at it, they'd be like, I don't even know what to look at because someone literally just told their life story into this file? Like, what have you found in terms of, that's great that we can document so much more, but is that actually helpful?
So still we're using a structure that we've been trained as medical students, as specialists. We use a complete structure. So it tells that story in a way, and it's not jumping around between the structures because you think in real time exactly what you were doing and been trained. While if you're typing, that is all over the place, and then you had to go back and correct it. Yeah. So definitely there's more documentation, but it tells a story. And remember, this notes is down the track. It can be used for legal cases, for revenue recapturing, release of information to patients, police statements. So now suddenly I find it tells a story, specifically if you had to go maybe in a month's time or 2 months' time when you can't remember exactly anymore. You need to think about the case, what had happened that day. Now when you look at your notes, that's fine. Copy and paste, or just take your notes out there exactly as you need it for anything.
Yeah, I can expand.
You mentioned that in the.
Yeah, I was going to expand on that question as well. So yes, the notes are more comprehensive, but what I find is with, and I think this will benefit the junior doctors, especially if they're working in under a sense of urgency and have some time pressures. They will probably generally just put down significant positives, and they will probably omit some significant negatives. So say you would have a patient with chest pain and they would just say, the location of the pain, the nature of the pain, other things like that. But it's just as important to say things that aren't there. So they do not have hemoptysis, they do not have shortness of breath, they do not have calf swelling. And a lot of the time, I think significant negatives are lost, especially when they're under time pressure, because they just think it's not there, I don't need to document it. Whereas I really need to know what isn't there as well as what is there to make a proper decision about what's happening with this patient.
Not to get sidetracked, but I've heard that discussion too, if there's clinicians thinking, well, and this is more relevant in, areas where you might take a lot more images with your documents and with your clinical documentation and maybe more so in the US or other areas where there's more litigation and things, but there might be a concern from clinicians like, well, I don't want to document that because in the event I miss something, then I might get in trouble. But I think what you've brought up some really good examples of, you want to make sure you document things so that if things happen, like
you've got yourself covered.
Yeah.
It's absolutely. I seen from my notes, which went to police statements, the amount of information there is what the police need. I had a case one day when I didn't know they're going to come and ask the next day for a statement. And as they normally do, they did come and argue and said the doctor didn't document it. And the staff who was tasked to release the notes to the police said, did you read the notes? And I said, yes. And I said, well, the doctor said exactly in this paragraph and that paragraph that mention that blood test has been done or not been done and the outcome of it. Yeah. So, again, it's not just saving for us as clinicians time, it's saving time for people down the track, your administration. Now, I know we're in EMR and not anymore writing in pencil now. No one could have read my handwriting, and there's probably a problem we're having with electronic records as we de-skill to read, be able to unclassify our clinicians' handwriting. But now it becomes so better with the voice to text that you do have a much better story to tell.
Something I heard as well you mentioned, Andrew, was this point around timestamping and being, particularly useful in your day-to-day. Did you want to mention something about it?
Yeah, so I guess it's sort of almost a flow on from doing documentation in real time. It's just really nutting down to exactly when something happened. So probably the biggest utility that I can see is in a very hectic resuscitation or trauma case. So particularly if it was to go to a coroner's case and they'll be assessing exactly the management that the patient had, rather than just a vague sense of this happened during the 30 minutes that the patient was there, they can see exactly what time it happened and in what order. So the example that I gave in the talk I gave this morning was a medical resuscitation for a patient who was found down in the car park just outside the ED. So we had no pre-notification, we had no team sort of set up and ready to go. So situations like that are certainly pretty hectic, and a lot needs to happen in a short period of time with a disorganised team. But despite this patient having an extensive amount of work done in the first few minutes, so, 2 IOs in and then IV lines and intubated and on the mechanical CPR and a multitude of medications and a VBG coming back, everything was documented down to the second, because we had a senior nurse running as a scribe nurse for that one while I led the resuscitation, and they used their DMO. They'd set up one button on the microphone as a timestamp, so they'd hit that to the second, they would say adrenaline, given, second IO inserted, similar like that. So despite it being very hectic and no pre-planning whatsoever, that still remains the most comprehensive resuscitation note I've seen in terms of the actual progression of events.
It's not just in the trauma way. We can see advantage in med calls or medical emergency calls. I see advantage in medical or obstetric med calls too, when you've got a really busy environment, and it's very important then to document the timestamp exactly as it happened. So a huge impact on the nursing staff too. Post resuscitation, I would say probably on average, Andrew, about 45 minutes. You sit there in the old days and how this time and this disagreement, no, this medicine was given that time, no, this one was given for. It's absolutely now you walk out, have a look at it, and it will take you about 5 minutes to reconcile the whole scenario. Interesting, most of this type of scenarios happen close to the end of your shift. So that could cause that clinicians go home probably an hour and a half later home. Distressed because they also look, did I done my notes correctly? Specifically, if I know this case will get to the coroner. And you go home and you don't sleep, you come back the next morning. So a huge impact on the well-being of the clinicians. And I think it's a big factor that it will reduce clinician burnout.
Cases like that as well, and it's probably a point that you were going to bring up, not only is it very sort of intense and hectic from the clinical side of things, but those sorts of cases also have maybe withdrawal of care, or having family discussions about exactly, how unwell their loved one is. And capturing that in a more narrative way, a more prose, I think is beneficial. It feels a little bit more human than just putting down dot points saying, patient's wife was notified of this and stuff. You can talk more on a human level, and I think that's beneficial.
Specifically, quite often the family will ask the release of the information of the notes later on, just to get closure about the case. And now when there's a more narrative and better compassion written in it, definitely will reduce anger for the patient's family, as well as help them to close their book, get closure of the case also.
Yeah, I've not considered that whole point around, the waiting on those notes from a patient's point of view. Obviously, the patients and carers have rights to access that information, and we're long gone are the days where clinicians would take secret notes about patients about what they really thought and all that kind of stuff, and that's not how health care should be delivered. It's about the humans. It's about having that human care. Gents, I feel like we could have this chat for another hour or two, but to tie back to one of those points, I think you just called on really early on, Peter, about your own experiences of implementing technologies. I guess for health systems, hospitals, even just people in a clinical setting looking at implementing technology, particularly speech recognition technology, any advice you can give? I know you mentioned at the start, engaging those influential clinicians up front, getting their buy-in. Is that some of the themes there?
It's absolutely. I did review the lessons learned, and then I did realize one of the missing parts of a success of a pilot is that it needs to be driven by the clinicians. It needs to be believed by the clinicians. So many pilot programs we've done in hospitals and implemented patient flows, and you wonder why didn't it work? It's because it's not driven by a clinician. So we did really focus on the clinicians. Who's your influencer? Who can change the journey? And who's the mentors in the hospital? Who's the junior doctors looking up? Who's their role models? So I did use it very effectively in DMO pilot, and I did get the advantage out of it. And I would advise any facility to implement DMO, you need the clinicians to drive it. They need to be the leaders in it. Otherwise, you will not be a success. If you let a, unfortunately, administrator do it, yes, they're good by oversight of the project, but it needs to be sold by the clinician. He needs to drive it. In comparison, and it was for my eye-opener when I look back at photos when we did go live with EMR. They said clinicians there slamping, jumping on chairs, throwing keyboards around. Now, when I look at after DMO and if we've got a set of photos, everyone is smiling in that photos. And that was for me, wow, that's a happy clinician.
Must have got extra pizza. What is it? They get the pizza out and everyone's happy. Is that? Yeah. No, but you're right in terms of engaging those stakeholders and getting involved.
Absolutely, engagement by the clinicians, and that including your medical and nursing staff. And we did went now further with allied health, and interesting psychologists was really engaged and drive it in the mental health area. We did thought the mental health clinicians, medical will drive it. But when we did go out and get a combination of psychologists and your psychiatrist, the psychologist was driving it tremendously. Because they take about up to 3 hours to do a comprehensive report. Yeah, right. Now they do it within 45 minutes. So that's significant, but that message that changed how mental health clinicians start working too.
Any other thoughts, Andrew, from the front line?
Oh, well, I guess just what Peter had said, like clinicians driving it and being sort of the influencers in a way. I guess this podcast could perhaps act as a vehicle to maybe let people be a little bit more open-minded about it, because I never actually envisaged myself as being an influencer in that way. I really thought it had no place in the ED, and I really just gave it a go as a favour to a friend in a way. Yeah. and like I've said to many people, I'm now dependent on this technology. So if anyone is listening here and they seem skeptical about it, I think just give it a go.
Give it a crack.
You might be very surprised about how quickly it improves your clinical practice. And again, you can become the role model for the juniors and then drive it within your own health service.
It's a great message for any technology implementation, yeah.
So, Andrew, you never did realize why did I choose you initially.
Yeah.
So I did deliberately take 5 people into the ED, and specifically that was one of the reasons. Who's the influencer? Who's the mentor? Who's the one who's the junior doctors look up? And that's one of the things I did see Andrew is he's a mentor, he's in teaching involved, he's the young generation, versus the old generation. Again, but if he makes a success of it, then the rest of it. So I was base my choice of candidates for the pilot program on that.
Yeah.
And it absolutely worked. And that's one of the ways to roll out any digital project in the hospital. So
I thought you might have just seen how often I need to go to the coffee shop and trying to free up time for me.
So now I did gave my secret away.
But you know what? There's so many great lessons and opportunities for other health systems around Australia to implement technology and voice recognition within their settings. Andrew, Peter, I really appreciate you making your time after this event and your busy schedule to come and have a chat. It's been really valuable. Thank you so much.
I think we just touched the tip of the iceberg so far of voice recognition. It can do so much more for us in patient safety, patient care, patient journey, and for our own well-being.
Yeah. I would encourage anyone to reach out to the digital team, or if they even want to talk to me personally as my experience as a full-time clinician using this, I'd welcome that.
Careful what you wish for.
Yeah.
Thanks, gents.
Brilliant. Thank you.
Thank you.
For more content and community about technology and healthcare, visit talkinghealthtech.com.